This is about Mr. M, who is a 39-year-old man recently diagnosed with PL-HIV in outside hospital and sputum-positive tuberculosis on ATT, who has presented to us with complaints of altered sensorium for the past 2 days. He was apparently well till 2 months ago when he had complaints of intermittent low-grade fever with no chills and rigors, and there was a history of cough associated with mucoid expectoration and no hemoptysis. There's history of loss of weight and loss of appetite. There was no history of seizures or alcohol consumption or focal weakness, anything that he complained of. So he was evaluated thoroughly outside in a government hospital and was started on ART on 10th of April 2019. His CD4 counts which were documented then were 11. He was found to have, simultaneously they have done a sputum test because he persistently complained of cough, and then they were found to he was found to have sputum positive tuberculosis, and he was started on ATT on 15th of April 2019. However, there was no clear thing whether he was discontinued ART during that initial treatment of ATT or not, but 2 days later of initiation of ATT he developed icterus, and 10 days into the treatment he developed altered sensorium. So when he came to the casualty, his GCS was 14/15, his vitals were stable otherwise. He had pallor and icterus, he had asterixis. His GRBS when he came was 20, and subsequently it was corrected and was 60 and later on 80. On systemic examination, his chest examination revealed bilateral crepitations in the infrascapular and the infraaxillary regions, which were more on the right side than the left side. CVS, S1 and S2 was present, normal. Perabdomen was normal. CNS, there was no neck stiffness. He was moving all 4 limbs. He is obeying commands. But on fundus examination, on the left eye examination, there was some hemorrhagic appearance of the fundus with some exudative kind of picture with a loss of vasculature in the 4 o'clock region. So it's not the patient's, I was not able to get the patient, but it typically looked like this part. So and then we the differentials that we have considered at that point of time were hepatic encephalopathy, because he came in with ATT induced, drug induced liver injury kind of picture, and metabolic encephalopathy, meningoencephalitis, and any other opportunistic CNS infections, his CD4 being 11. So on evaluation, his total counts were 6,100, hemoglobin was 7.8, platelets were 1.3 lakhs. There was direct hyperbilirubinemia, and there was elevated SGOT and PT, and alphas was 130. PT INR, however, were normal, not suggestive of not enough to call acute liver failure, and there was hyponatremia. His sodium was 122, and urea creat were normal. CT brain was done to rule out any focal lesions, which was also normal. He was positive for HIV-1 antibodies, and the CD4 which was done in our hospital has come as 13. So subsequently, because of the altered sensorium and because of a doubtful presence of hemorrhage kind of picture in the eyes, we went ahead and did a CSF which showed normal counts, normal glucose and protein, but multiplex PCR was CMV positive, which can also be present in a latent phase. So that is when we have went ahead and discussed with micro department and have done this quantitative PCR from the CSF, which is not usually done, and they have reported it to be log 4.12, which is positive. That's what they said. It's not normal, but it's abnormal definitely. So then we had seek the help of ophthalmology department, and shell eye referral was sought for, where they have commented saying bilateral fundus examination was suggestive of CMV retinitis. So we'll look at CMV retinitis. It's the most common serious ocular complication of AIDS, first reported as a complication of AIDS in 1982. CMV retinitis occurs in almost 21 to 44% of patients with AIDS, primarily in those with CD4 counts being below 50 cells, CD4 being below 50. So pathogenesis wise, there are many hypotheses which suggest that CMV retinitis results from the hematogenous spread of CMV to the eye, but there are some studies which were specifically done in transplant recipients in which they said that when there is a decreased CD4 activity, there can be CMV antigen, CMV infection which replicates in absence of the CD4 cells. So CMV retinitis is characterized histologically by full thickness retinal necrosis and edema that is subsequently replaced by thin atrophic scar tissue. The scar tissue is susceptible to tearing, which can lead to subsequent retinal detachment. So without antiviral treatment or immune reconstitution, the retinal lesions usually enlarge centrifugally and they can also lose their vision. So the portions which are destroyed by CMV, they do not regenerate functionally. Thus, the main goal of the therapy for CMV retinitis is to prevent further retinal necrosis and loss of vision. So clinical manifestations usually they come with complaints of blurring or loss of central vision. They can have blind spots. They can have floaters, photopsia. There were studies which said that the people who complained of floaters and photopsia, this will be a single symptom which is very much suggestive of CMV retinitis in AIDS patient with CD4 less than 50. So the main complication that CMV retinitis, if further progresses, can cause retinal detachment. So the other complications are anterior uveitis, vitritis and cystoid macular edema. So the main diagnosis will be indirect ophthalmoscopy, which reveals yellow, white, fluffy or granular retinal lesions, often located close to the retinal vessels and are associated with hemorrhage. Lesions, they can be described as fulminant and edematous versus indolent and granular based on several factors, including the degree of retinal opacification, retinal hemorrhage and lesion shape and location. So it's not diagnosed with the help of blood analysis or the blood quantitative PCR or CSF PCR. It may not be diagnostic. So in a study of patients with advanced AIDS and CMV viremia detected by PCR, fewer than 50% developed CMV end organ disease at 1 year despite receiving no anti-CMV therapy. And conversely, using the above methods for viral detection, CMV viremia is detected in less than half of patients with active retinitis. So the important test that is to be done if you suspect a CMV retinitis would be indirect ophthalmoscopy. So the treatment includes antiviral therapy and antiretroviral therapy. When you give CMV antiviral therapy, it includes two ways of giving it. It's systemic and intravitreal. So for a newly diagnosed infection, it always depends upon what kind of effect of the vision does the patient have. So if in presence of immediate sight-threatening lesions, we will have to go with intravitreal and systemic therapy. Whereas if it is without sight-threatening disease, systemic therapy would suffice. So if it is like if it is already present and then it was treated and subsequently there was a relapsed infection in the same person, we tend to give a dual therapy. If not, if the patient is already initiated on ART, we can go ahead and give a single agent. So the treatment includes two phases, which are induction phase and maintenance phase. So the induction phase is for either 14 to 21 days. Most often it is a clinical decision rather than a time frame saying this is the particular time that we are supposed to give induction for. So primary regimen consists of valganciclovir, which is given 900 mg BD for first 14 to 21 days with the help of recurrent reviews with ophthal people frequently and examining the fundus. Whereas maintenance goes till 900 mg OD per day. And whereas if the lesions which are present are life-threatening, intraocular implants were there previously which were now not being given, whereas intravitreal injections we can either give 2.5 mg per injection with combination with oral valganciclovir or repeated injections per weekly for 2 to 3 weeks in combination with oral valganciclovir. This is in the induction phase, whereas in maintenance phase, you can just give valganciclovir, or you can also give intravitreal ganciclovir 2.5 mg per week. The other medication that we can use is foscarnet. So the alternate systemic regimens for the patients who will not tolerate valganciclovir are this IV ganciclovir, which is a standard dose of 5 mg per kg IV every 12 hours for 14 to 20 days, whereas high dose therapy is a salvage therapy in which you give higher doses of the same. So IV foscarnet is the other medicine which you can give, which can even be given in induction and maintenance phase. So systemic therapy continues as a standard treatment of CMV retinitis as of now. So there is a study which is done in the group of people who were receiving the treatment, in the group who were receiving valganciclovir versus ganciclovir. They did not find any difference per se, saying that it's IV is superior to it or not. More or less, oral is as effective as IV ganciclovir for the induction therapy is what they have found. So how long do we have to give the therapy? So it's typically administered for 14 to 21 days, but as I've already mentioned that it depends mainly upon the clinical decision. So maintenance therapy, when do we discontinue the maintenance therapy? We discontinue it if the patient meets following criteria: if they have quiescent retinitis and the lesions have been treated for at least 3 months of the initiation of the treatment, and the HIV viral load now is suppressed, and the CD4 count should be more than 100 cells for at least 3 months. So in our patient, we have initiated him on injection ganciclovir with regular follow-up with ophthalmology department and changed over to valganciclovir after 4 weeks of treatment. But then after that, he developed leukopenia. So he was discontinued currently, and he's being followed on OPD basis for the reinitiation of valganciclovir and Septran. Take-home message: the fundus examination in HIV patients is important, and oral valganciclovir is equally effective as systemic IV ganciclovir.
Thank you. Are there any questions?
What your diagnosis of this encephalopathy and hepatitis virus?
Like the final diagnosis that we have made is, he had multifactorial. When he came in, he was definitely having flaps, and he had hepatic encephalopathy features, and he also had hyponatremia, and within 36 to 48 hours, actually after the sodium has improved, he has woken up. So that is one other thing. And
What was the hepatic encephalopathy secondary to?
He was on ATT, which would have caused delay, and then he went into problem.
Okay. And so you think his CMV is a primary CMV disease, or is it IRIS2?
We treated it as a primary disease because he
The
had
treatment of IRIS is also the same? Because all his symptoms seems to have started after
the initiation
ART,
of ART. Yeah.